It is. And so there are patients that are continuing to have benefit. And as you can follow the curves, you see that there are patients that continue to stay on therapy and are deriving benefit out past 4 years. You're going to have a decline. Unfortunately, patients do progress and succumb to the illness, so the survival curves do drop down. We also noted that in our particular trial, when you look at the far right of our Kaplan-Meier survival curve, you see a phenomenon of the two curves coming together, and that is, we did extensive evaluation as much as you can within the limits of your data, showing that a driver of that was simply patients that were randomized to the comparator arm, which would be sunitinib, were progressing as they were earlier, twice as early as they were on the other arm, and they were going on to other active therapies. And we do have other active therapies that do impact survival in this cancer. So patients can be rescued, if you will, sometimes with later line of therapy. And if you do an analysis, one of the analysis we did not show, so it's probably not fair for me to talk of, we did look at PFS2, which is kind of a different way of looking at the impact of subsequent lines of therapy. And there'll be a publication that comes out with that data, but it looks positive, and I'll just leave it at that. But if you look at another statistical maneuver, which is just replacing patients, censoring and replacing patients, you can see that if you take away patients that did go on these subsequent therapies, the curves are, as we showed them, remain separated throughout the duration of the survival curve. So if you take away the influence of the second line and later therapy on it, there is a maintained survival benefit. There's a clear separation of the curves at the far right. You don't see them come together. And so we feel very comfortable that on the intent to treat analysis, that the two survival curves coming close together was a phenomenon of post-progression therapy, patients going on other therapies which salvage that. The other thing, and I'll be a little provocative here, is people will say with IO-TKIs in general that the curves don't look quite as nice as the intermediate and poor risk curve of Ipi-Nivo. But we must remember in Ipi-Nivo curve, and its approval in the United States is in the intermediate and poor risk patient. And so they show, rightfully so, their intermediate and poor survival curve. And it shows separation, maintained separation throughout the duration. And everyone talks about, this tail of the curve. And since our intent to treat analysis, we're showing favorable, intermediate, and poor, and the approvals for the IO-TKIs are in all three of those groups, we show all three survival curve, the intent to treat, where they come together and they don't maybe look as attractive. But that is influenced by the favorable risk group. So we know when we look at overall survival, it's really hard to show an impact. You get greater PFS, greater response rates of using an IO-TKI over single agent TKI, but the impact on survival is not, the group does so well anyway, it's not as visible. And so if you take out that favorable risk group and you just look at our intermediate and poor risk survival curves, they look just as attractive or even more so than the Ipi-Nivo. And that never gets mentioned when we have our discussions, because I guess we're left with talking about our intent to treat of all three prognostic groups. But that allows people that sit in the camp of it needs to be Ipi-Nivo in everyone. It allows them to boast and say that their curves look better and all this stuff. But I think, us more sophisticated, we realize it's just because the favorable risk. In fact, there is a favorable risk group of the original Ipi-Nivo trial, and it's just not shown. If you look at their favorable risk, which had been reported, they do very bad on Ipi-Nivo. And if you throw that curve in there, you'd be looking the same as us. So I think we need to really be a little bit more sophisticated than what we have. And if you were at the meeting and listened to the discussion that happened after presentation, there was a little back and forth with some of my colleagues asked questions, and there's definitely two camps when it comes to which is the best for patients long term. And I stand behind the IO-TKI. I do use IO-IO in select individuals, but it's a minority of patients who have low volume disease. But if I have patients that have more significant volume of disease and they really need to get a response, then I'm going to choose an IO-TKI regimen. I'm going to choose lenvatinib pembrolizumab because it has the highest likelihood of benefit to that patient. And you just don't have, you lose 10, 20% out of that if you're choosing ipi-nivo. So it becomes a lot more challenging when we start comparing amongst the IO-TKIs themselves, because then, you do see cross-trial comparisons are challenging. If you go just on the data, what's been presented, the IPI, len-pembro has the strongest data and should be congratulated for that. However, the population in the trials were slightly different, and you can talk away why maybe one performs better than the other based on that. But at the end of the day, the data is what the data is, and the data shows the strong, robust activity. I've been able to, in my co-investigators report with the 23 months of additional follow-up, that data remains robust. Patients and doctors should be very comfortable that this wasn't a figment of their imagination, that the early data truly is maintained, and they should be very comfortable in choosing this as their regimen of choice. We had no new safety signals, and so len-pembro remains, in my mind, the regimen to beat when one is comparing against an IO-TKI.